Okay, so we'll be discussing today. Today we'll be discussing the principles of wound healing. Um, Let me first start by defining wound. A wound is a breach in the continuity of a tissue or a breach in the integrity of a tissue. That's the definition of wound. Now, this differs from ulcer, where ulcer is a breach or discontinuity of an epithelial lining. What this simply means is that all ulcers are wounds, but not all wounds are ulcer. Take for instance, if if there's an injury to just only the skin, it can be considered as an ulcer. If the wound extends beyond the skin, involving the fat layer, the muscle layer, is considered as a wound. If there's a wound in the stomach and involves only the gastric epithelial lining, it's regarded as an ulcer, gastric ulcer. But once it extends beyond that, involves the muscle layer, it's called, but it has not perforated, it causes a gastric wound. If it's just an abrasion of the epithelial layer of the stomach, it's called gastric erosion. So having said that, again, the difference between a wound and an ulcer is that a wound involves not just only the epithelial lining, but the underlying lining, or it just involves the underlying tissue alone. But for an ulcer, it just involves only the epithelial lining. Now, wound and wound healing cannot be separated. They cannot be dealt with in isolation, because once a wound occurs, the body tries to restore the damaged tissue to it, or at least to the best of its ability, to the original state. So the process by which the body tries to restore damaged tissue to its original form is described as wound healing. So for the purpose of definition, wound healing is physiologic and anatomic changes that result in the restoration of normal tissue structure and function. What this simply means is that once there's injury, the body tries, or it puts all the mechanism in place to be able to return back the body damaged tissue to its original state. And that process of doing that is what is defined as wound healing. Now, how do you classify wound? There are many classifications, but the one I want you to focus on is just the CDC classification, which classify, CDC means Center for Disease Control classification, which classify wounds to clean wound, clean contaminated, contaminated, and dirty wound. What does a clean wound mean? A clean wound means that it's commonly clean wounds are generally surgically created wounds. They are wounds in which there is no breach into a hollow viscous. Commonly, clean wounds are wounds that you create yourself as a surgeon. And this wound, there are three basic hollow viscous in the body. They are the respiratory system, the gastrointestinal system, and the urogenital system. So any wound outside these three systems is commonly considered as a clean wound. This statement is not exclusive anyway, but commonly any wound that is outside the system that you create yourself is considered a clean wound. For instance, if there's a lump, let's say in the hand, and you create a wound to remove that lump, that wound is called a clean wound, because you have not breached either of the respiratory system, the digestive system, or the urogenital system. So such one is considered as clean wound. If, for instance, again, there's a lipoma in the anterior abdominal wall, you go create an incision and you remove it. As far as you have not breached these three systems, is considered as a clean wound. Now, how does question present like this? They may tell you that a patient this presented to you has a lipoma. And ask you what type of, and then you go and remove it. They ask you what type of wound is this? You see that as a clean, contaminated dirty wound. Or they may go straight forward and say, which of the following is considered as a clean wound? So once you look at the options, you look at the wound in which you've not breached any of the system, or wound that does not have infection. For instance, a wound, an abscess, or what they call boil, in the hand, though it has not breached the system, it's just not a clean wound because there's an infection there. An abscess simply means the body trying to fight an infection and then wards it off, and then some of the cells die and they form pus. So an abscess is not a clean wound, even though it's not in this, you have not breached any of the system. So you may see something like lipoma excision, haenorrhaphy, those are clean wounds. So the question can come straight forward and tell you which of the following is considered as a clean wound. Haenorrhaphy, lipoma, lump excision for breast, those are clean wounds because you've not violated any of the viscous system. The next classification is clean contaminated. In clean contaminated, these viscous structures are breached, but you entered it in a controlled manner. That means when you enter into any of these viscous system in a controlled manner. For instance, once you do an appendicectomy for patient with acute appendicitis, it's called clean contaminated wound. Once you do a cholecystectomy, that means you remove the gallbladder in a patient that has cholelithiasis, it is clean contaminated wound. In that instance, the gallbladder or the appendix is inflamed, but you have a controlled entry into it. That means you entered it in a way that you did not breach the gut system. And there are ways you do appendicitis that you don't actually injure the bowel. So in that instance, do you've breached the viscous, because the appendix is a vestige of the gut. It's a vestigial organ, that means a redundant organ of the gut. But even though you've got into it, but you've not opened into the gut system, because there's where you tie the, what do you call ligate? You ligate or tie the appendix at the base, so that by the time you amputate the appendix, you've not spilled, you've not overtly spilled the intestinal content into the body. So it's considered as a clean wound. So come on, they may ask which of the following is, they can go straight forward and say which of the following is a clean contaminated wound. And commonly the option to normally put is it's appendicectomy for appendicitis, or they may put cholecystectomy for cholelithiasis, cholecystitis. When you see these are the two common options to put. When you see this, you know it's a clean contaminated wound. Now, what's the significance of all these classifications? The significance of all this classification is that it helps you plan for the patient and prevent overt or covert infection. Now, for a contaminated wound, in this one, you don't have, you enter the viscous without any controlled entry. For instance, a patient that has appendix, that has complicated appendicitis, like an appendix mass, appendix abscess, those are contaminated wounds. So when it says, which are the following say contaminated, you see appendix, you see complicated appendicitis, like appendix mass, appendix abscess, those are contaminated wounds. Then dirty wound obviously is a wound that has pores, foreign bodies in it. And common example they will give you will include things like ruptured viscous. Anytime they tell you that this patient has gastric perforation, typhoid perforation, any of the perforation you see in the abdomen is a dirty wound. Or someone that has gunshot into the abdomen and they saw foreign body like bullet pellets inside, or they saw plastic containers, plastic bullet materials inside, or there was feces in the abdomen. Those are dirty wound. Now, the question will come again, like which of the following example of dirty wound? Just look for anything that, just look at the option and you see the one that has that fecal content, fecal contamination, pus, foreign bodies. These are the options. So you see, we tell you typhoid perforation, gastric perforation, ileal perforation, TB perforation. When you say anything that involves spillage of content of the intestine into the abdominal cavity, then it's a dirty wound. Now, what is the relevance of all this? Commonly, clean wounds, you don't give prophylactic antibiotics, but for the other, you want to give prophylactic antibiotics. For clean contaminated, you want to give prophylactic antibiotics. For contaminated and dirty wound, you want to give both prophylactic and therapeutic antibiotics. So for contaminated wound, you want to give therapeutic antibiotics. For clean contaminated, you want to give prophylactic antibiotics. What's prophylactic antibiotics and therapeutic antibiotics? Prophylactic antibiotics are antibiotics that you give to prevent clinical infection, to prevent infection. Why a therapeutic antibiotics and antibiotics that you are giving because it's an ongoing infection? So having said that, the other type of classification I will not want to bother you about because it's likely not going to come out in your exam. Again, the ones that will come out to your exam are the CDC classification, which is clean wound, clean contaminated, and dirty. The other type of classification may likely not come out, so I'm not going to discuss the other type of classification of a wound for you. Then, wound healing, like we said, is the process, physiologic and anatomic processes that try to restore a damaged tissue to its original state. Then how does the body does this? The process by which the body do this is what we classify as the intentions of wound healing. And how does the body heal? The body can heal via what we call primary intention, secondary intention, tertiary intention. Then there's a quaternary intention. This quaternary, I will also want to bother you about it. Again, this slide was not prepared primarily for this lecture. It was prepared for a postgraduate lecture. But then there are certain parts that you guys will need. So I will just bring those parts for you. And then the other part, I will not bother you about it. Now for primary intention, what does it simply mean? This is healing with minimal scarring. The aim of this, the body achieve this healing process by forming little to minimal scar. And this commonly occurs once a wound edge is approximated. That means there's a wound, you go and then you suture the wound. Once you suture the wound and bring the edges together, you've created a process.
Sorry, sorry, network was back. Excuse me, sir.
Where did you not get up? Where did you get up to first? Let's start from this. So we can go back.
You said healing with minimal scarring.
Yeah. Okay. I said the process by which the body, there are different methods that by which the body tries to heal damaged tissue, and those process of healing is what we classify wound healing into primary intention, secondary intention, tertiary intention. I said the quaternary intention, I may not want to bother, I will not bother you about it at all. But I'll tell you about the primary, secondary, and tertiary intention, but that's what you will need. For primary intention, the body aim here is to heal with minimal scar. And for this to happen, it will need an external intervention. Commonly, not all the time. Now, how does the body heal the minimal scar in primary intention when the edges are brought together? So for instance, a wound, the patient comes to you and the wound, you look at the wound, you clean the wound, you prepare the wound, after preparing the wound, you then bring the edges of the wound together by suturing together. When you suture the wounds together, that process of healing is called primary intention. Are we communicating? Are we communicating?
Yes, sir.
Let me come again. once a wound, once you meet a wound and then you saw that the wound edges are apart and you bring it together with sutures or with staples or with even with strip, by bringing the edges together, you are ensuring that the wound will heal with minimal scar because the two edges are in contact together. And once they're in contact, then the scar that will form will be minimal. So in that instance, the aim of wound healing is by primary intention. Commonly, again, sometimes if you make it, if an individual has a small cut in the hand, and then the edges are together, the wound will heal with minimal scar, and such healing is called healing by primary intention, because the scar they form is tiny, linear, and straight. It mustn't be straight in nature, but it's tiny and linear. So healing whereby there's minimal scarring is called healing by primary intention. Are we communicating?
Sorry, sir. I have a question.
I'm with you.
Okay. For this primary intention now, because I've seen some surgeries that are done and the scars are usually
Large.
very gross, like big. So is there like a measurement to measure the scar to differentiate it between the scarring in primary intention and the scarring in secondary, or is it that every surgery that was closed, like every closed or sutured wound is already healing by primary intention?
Okay, now every sutured wound ought to heal by primary intention. But if you see a broad scar in a sutured wound, it's one of two things. It's likely that the intention initially was primary, but the wound healed by secondary intention. And commonly, that wound may have been infected during the process of healing. So that converted the wound healing from primary intention to secondary intention. So though the aim initially was primary intention, but the wound eventually healed with secondary intention because that wound initially was infected. So if we say a broad scar, just know that that wound healed by secondary intention. Even though the wound was initially sutured, it was sutured. The wound did not heal by primary intention, it was healed by secondary intention. Then again, there's no classic diameter for measuring broad scar. Broad scar commonly is a clinical diagnosis, is a subjective diagnosis where the width of the scar is considered large compared to the length of the scar. So for a narrow scar, the length is usually there's usually longer length with tiny width. But in a broad scar, the width is almost, it may sometimes be larger than the length. It may almost be the size of the length of the wound, or a little bit lower than the size of the length of the wound. But commonly, if it's in a narrow scar, is one that the length is longer and the breadth is tiny, like a linear line, like a line. So any wound that you see that as like a line is it healed by primary intention. Any wound that the scar is broad is it healed by secondary intention. Are we together? Are we together?
Yes, sir.
Please, if you don't understand, let me know. I will come back again. My aim is to see that at the end of the day, whatever we deliver here is well carried home. I'm not in a hurry to end the lecture or run through everything. My aim is so that you understand these things. So when you see questions, you use the same principle to answer them. So for secondary intention, the aim of healing is by granulation tissue. What this simply means that if the wound, when you see a wound and you won't keep dressing the wound until the wound heals, it's going to form a broad scar. And that healing is by secondary intention. Are we communicating?
Yes, sir.
So for tertiary intention, what this commonly means that it's a combination of it's a modification of healing by primary intention. What this simply means that the wound when at the point of seeing the wound was not ready for closure. Either it is infected, it is edematous, as in severely edematous, or a foreign body in the wound. That means at that point in time that the wound is being evaluated, the wound was not ready for closure. So commonly in healing by tertiary intention involves initial care of the wound and thereafter closing the wound primarily. What this simply means that you see a wound, the wound is either the wound has pus, has foreign body, you keep the wound is then debrided, and then after debriding, the wound is dressed for about 48 hours. Then that within that period, the wound now transits and becomes clean wound. When it's not clean wound, the wound is not being closed. The wound will not be closed primarily by suturing the edges together or stapling the edges together. So that process whereby in this initial care of the wound with dressing and debridement, and thereafter after 48 hours, the wound is not closed by suturing or stapling, is called healing by tertiary intention. Is there any question? Is there any question?
No.
So for continual intention, I will leave that that's postgraduate. It's not going to come out in your exam. So for wound healing, there's usually a balance between scar formation and tissue regeneration. What that means is that the two it's like a pulley. One try to outsmart the other. Some tissue we prefer to heal by regeneration, some which I prefer to heal by scar formation. And in that instance, the one that takes precedence outweighs the other, and that gives its the type of appearance eventually that the wound will take eventually. Having said that, they are basically 3 phases of inflammation. Again, in your books, you will see it as 4 phases of inflammation. And I want to discuss that 4 phases. The 4 phases are hemostatic phase, inflammatory phase, proliferative phase, maturation and remodeling phase. In some of your book, you may see it as 5. You see that hemostatic phase, inflammatory phase, proliferative phase, maturation phase, and remodeling phase. But most books you see it as 4 phases. Again, inflammatory phase, proliferative phase, maturation, and remodeling phase. Now, though there are 4 phases, let me emphasize that though they are for the purpose of discussion, they are divided into 4 phases, but these phases occur simultaneously. It's not independent of each other. That means you don't move from one phase. After you are done with one phase, you move to the second phase. No. Some part of the wound may be in inflammatory phase, some part may be in proliferative phase, some part may be in maturation phase. They all occur almost at the same time, but just at the different part of the wound that may be different part of that same wound may be in different phases of the wound healing. Now, for the hemostatic phase, usually has the following process in it: transient vasoconstriction, coagulation, and vasodilatation, and increased capillary permeability. So having said that, I said for the hemostatic phase, for your level, I'm trying to discuss it at your level. For your level, there are 4 phases: the hemostatic phase, the inflammatory phase, the proliferative phase, the maturation and remodeling phase. For the hemostatic phase, it usually has basically 3 components: transient vasoconstriction, coagulation, and vasodilatation. For the inflammatory phase, that's what we call chemotaxis, cell migration, and cellular response. For the proliferative phase, it has the matrix formation, blood vessel formation, what we call angiogenesis, and epithelialization. Then the last phase is the maturation and remodeling phase. Now I'm going to discuss these 4 phases for you now so that it becomes clear. once it's an injury to a tissue, each tissue in the body has blood vessel in it. So once there's an injury to the tissue, the collagen in the cells, in the around the blood, around the injured tissue, particularly the blood vessels around the injured tissues, once they're exposed, they stimulate the smooth muscles to go into spasm. That's what we call transient vasoconstriction. So that contraction of the smooth muscles or the blood vessels will lead to vasoconstriction. The essence is to limit blood flow through that injured tissue to further limit blood loss. Once this occurs, that same collagen that is exposed, once it gets in contact with platelets, the platelet itself undergoes changes and start degranulating, start releasing its granular content. Some of the content include adenosine diphosphates, alpha granules. These granules that they release eventually will kickstart the hemostatic pathway, and by stimulating the intrinsic and the extrinsic pathway of hemostasis. And that will then lead to what is called, eventually lead to platelet plug. The platelets start coming together with those granules, with those released granules, they stimulate more platelet to come towards the injured blood vessel. And then with the intrinsic and extrinsic pathway activation, they then further activate the platelets, activate fibrinogen to form fibrin. The platelet come together and stick together. By sticking together, they form a platelet plug, which then plug the blood vessels to prevent leakage of blood, so that patient does not eventually sanguinate completely from that wound. Fibrin is also activated by the intrinsic and extrinsic pathway, and then that further clogs the blood vessel to initially prevent blood loss. Also, when this occurs, eventually that vasoconstriction that lasts about 5 to 10 minutes lost its effectiveness, and then there's eventual vasodilatation. And this vasodilatation occurs because there's release of inflammatory mediators such as serotonin, bradykinin, high molecular weight kininogens. All these are vasodilators, even nitrous oxide in the endothelial cells. This released product causes vasodilatation, and with vasodilatation, there's increased cell movement from the blood vessels into the injured tissue. All these are in effect to commence the process of wound healing. That ends the hemostatic phase and then commence the inflammatory phase. For postgraduates, we merge these two processes together because they are not indistinguishable, they occur together. But for your level, because from your books, they divided this, since I'm orally dividing for you, as it is in your textbooks, as it is divided into hemostatic. When we see that in MCQ, the following phases occur in wound healing, you see hemostatic, you see inflammation, you see fibroproliferative, you see maturation, you see all of them like that. So you should just know. But for postgraduate level, we don't differentiate that. So having said that, that kickstart the inflammatory phase. And what does the inflammatory phase involves? Involves the movement of neutrophils from the blood vessels into the tissues. And this occurs immediately, almost within 12 hours. And what this happens, how does it move? That's also another question that may come up. Neutrophil moves from the blood vessel into the damaged tissue via the process called diapedesis. So it's a question that I've seen before in the past, long time ago. So it may possibly be a question in the future again, because nothing is absolute. Things repeat themselves again, over and over again. Then what's the function of why do this neutrophil moves from the blood vessel to the damaged tissues to go and engulf whatever pathogen that is there? Also, to monocytes in the blood vessel undergo conformational changes, they form macrophages, and then they also move to the damaged tissue. What are called the cellular migration pathway. Lymphocytes also move from the blood vessel into the damaged tissue. Again, once this gets there, again, the platelet initially that was in the blood vessel that was activated, like I said, it degranulates. It releases alpha granules, it releases ADP. It also releases cytokines, particularly platelet-derived growth factor, fibrinogen-derived growth factor, fibroblast-derived growth factor, fibroblast growth factor, platelet-derived growth factor, vascular endothelial growth factor. I'm listing this again, they come out in your exam, they do come out. Except they do come out in undergraduate exam, they come out also in primary exam. So my exam, many times, some of the questions are actually from primaries. So they release these following factors: platelet-derived growth factor, fibroblast-derived growth factor, they also release to some extent vascular endothelial growth factor. Vascular endothelial growth factor is also released by damaged endothelial cells around the injured tissue. We'll talk about all these factors eventually. There's also another factor called keratinocytes derived growth factor. We'll talk about all these growth factors in course of lectures. They may bring them, they may not bring them. So it's good you know them. So what does platelet derived growth factor does? It stimulates fibrocytes. Fibrocytes are cells that help promote synthesis of collagen, elastin, particularly collagen in the connective tissues of the body. So this fibroblast-derived growth factor secreted by the platelets stimulate the fibrocyte. Fibrocyte are quiescent fibroblasts. Fibroblasts that are just remaining, they're not doing anything, they're just relaxing, living peacefully on their own. But once platelet release fibroblast-derived growth factor, it goes to activate those fibrocytes. Those fibrocytes increase the mitochondrial activity, swells, the their color becomes more darkish, pinkish, and then they start fibrin production. And what does this fibrin do? They start collagen production, sorry. So once fibroblasts are activated, they become fibrous. When the fibrocytes are activated, they become fibroblasts. And this fibroblast starts synthesizing collagen, elastin, particularly collagen. This collagen are then deposited on damaged tissue to start the process of healing. Also, that is the cellular response we're talking about. And then this collagen, that leads us to the proliferative phase. This collagen themselves, they then arrange around on the wound itself, form a matrix for which other ground substances such as glycosaminoglycans, chondroitin sulfates, hyaluronic acid, all these ground substances then promotes the matrix for which the cells from the margins of the wound migrate through to cover the wound and heal it up and seal it up completely. Also, why this process is also going on, there's also, like I said, there's also the release of endothelial-derived growth factor. What this endothelial-derived growth factor does eventually is it helps to stimulate blood vessel formation from existing blood vessels. So blood vessels start growing from the existing blood vessel into the wound, and that will also help to carry nutrients necessary for the process of wound healing. And then once the wound eventually seals up, the collagen initially deposited on the wound are haphazard. The process of rearranging the collagen into linear arrangement is what we call maturation and remodeling. Those blood vessels that were initially formed start dying off. Eventually, the scar formed eventually from this process does not have blood vessel, and the collagen are arranged in a particular direction. In that process for which collagen are rearranged in a linear fashion, and then new blood vessels form in the wound in the scar are removed, is called maturation phase. having said this, all these are diagram of what we have been saying since. So like we said, transient vasoconstriction occur within a few minutes, usually about 5 to 10 minutes. There's initial vasodilatation, and that leads to, and this occurs because we said serotonin, histamine. We said we talked about nitrous oxide from the telea, so we talked about that before. That leads to eventual dilatation of this vessel. Once these vessels are dilated, there's movement of, we talked about neutrophil macrophages into the tissue. Particularly important are some of these factors. You should know this complement factor C3A. You should know this comes out. This complement factor, in addition to some of those platelet granules, promotes neutrophils to move into the cell, macrophage into the cell, to go and destroy those bacteria. So some of the chemotherapy factors that you may see in your exam include alpha granules, C3A, tissue and bacterial products. Please note this. It has come out before in undergraduates. It can also come out again. Again, we talked about cell migration. We talked about it before, where the cells move from the blood vessels, particularly neutrophil and macrophages, into the injured tissue. And it does that by the process of margination and diapedal. What margination means that the cells, the neutrophil are actually located around the center of the blood vessel while it's flowing. But with that increased vasodilatation, there's sludging, there's decreased velocity of the blood. So neutrophils eventually are pulled to the peripheral of the blood vessel. That pulling to the peripheral of the blood vessel is what is called margination. And then again, and that question that usually we ask again, once it gets to the peripheral of the blood vessel, it then attaches to the blood vessel, to the endothelial cells, before it then migrates via the epidermis, via what we call ICAM, VCAM, and integrin. Know that. ICAM is intracellular adhesion molecule. VCAM is vascular intracellular adhesion molecule. The integrins are what is in the neutrophils. Right? This question we have come out before, undergraduate level, primaries. You also come out in the exam. Now the neutrophil express what we call integrins, and then the blood vessels and the endothelial cells and the tissue cell express what we call ICAM and VCAM. Once this integrins and ICAM and VCAM attaches to each other, it's through this process that the neutrophil will now, and particularly neutrophils, will then move from the blood vessels into the tissue. And then they start moving in between cells, process what they call diapedesis. So note this, it has come out before, it may come out again. So okay, so like we said again, neutrophil moves within from the tissue from the cells to the tissue, usually within 24 to 40, usually from 12 hours upwards, or from 24 to 48 hours, you start seeing, you see enough of this neutrophil there. Macrophages start becoming dominant in the tissue, damaged tissue, by the second day. Lymphocytes get to the damaged tissue by the 5th day. Again, we talk about the fibroblast, how it starts secreting collagen, and then there's also formation of ground substances. There's also formation of hyaluronic acid, chondroitin phosphorus. All these are essential for laying down they are laid down on the wound bed, for which the adjacent non-injured tissue migrates. Now again, let me also explain something. At the margins of the wound, those healthy tissue start proliferating, and then they start migrating into the wound to seal up the wound surface, so that eventually there's no obvious physical wound again. If you are not understanding, please draw my attention. I'll come back again. Now, question you should take note is that tensile strength begins to increase at day 4 to 5. Then and that question they may ask you is, when does epithelialization ends? It ends when there's contact inhibition. When, like we said again, the cells on the margin start migrating into the wound from all directions. So at the point in time, they will meet. And once they meet, they stop migrating. And that still stops that part of the wound. From the other angle, they come migrate, and once they meet, contact inhibition occurs, and then they stop migrating. Eventually, all this will all meet together, and then wound will completely sealed. Now, note this part in dark ink. It has come many times. The peak tensile strength is achieved at 60 days, and that is 80% of pre-injury strength. Now, what is 60 days? 60 days, about 2 months, and that's about 8 weeks. So it may come out that peak tensile strength is achieved at 8 weeks. It has come out it comes out many times. So note this. Also, another thing you should note again is that is the collagen that you find. Initially, in the wound healing, what you have is collagen type 1. So initially, in wound healing, what you have is type 3 collagen. During wound healing, note this where it has come out before. Then in maturation phase, what you have is type 1 replacing type 4, type 3 collagen. Please note this. And the ratio is usually 4:1, but this 4:1 may not mean, I don't think I've seen, but this type 1 replacing type 3 collagen in the maturation phase, it has come out many times. So please note this. Now, these are some of the growth factors. Please note platelet derived growth factor, transforming growth factor, vascular endothelial growth factor, and fibroblastic growth factor. Please note this. They come out. Again, we said the platelet release transforming growth factor, beta platelet derived growth factor. Then vascular endothelial growth factor is released primarily by the endothelial cells of the damaged vessels. Platelet also release that also too. Stages of wound healing may not come outside in your exam, so I'll leave that. Then again, how will they measure tensile strength? Measurement of tensile strength, again, this may come out, it has come out before, can be done via the following process: microscopy, planimetry, tensimetry, biochemistry. They may not ask you to explain it, but just know that they may just come out in option, which are the following can be used to measure tensile strength. Microscopy simply means that we take the tissue and then look at it under the microscope. Number of collagen and the number of cellular component, vascular component, collagen you see in that particular tissue. We tell you the tensile strength and then the stage at which you want this. Then biochemistry is assessing biochemical events at each stage, the amount of serotonin, the amount of collagen can give you the tensile strength and the stage at which you want this. So I will not go into those, but just know that the process, the 4 major means of measuring tensile strength are microscopy, planimetry, tensimetry, and biochemistry. And then this healing in special tissues, well, just come outside, but I'll tell you one that I've seen that has come outside. Now for bone, they don't have particularly what's called fibroblasts. Rather, the action of fibroblasts is taken over by osteoblasts. The processes are almost the same, but yeah, instead of fibroblasts depositing collagen, osteoblast deposits is what takes over the function of fibroblasts and start depositing bone matrix. For intestine, The mucosa heals by regeneration. That means it replaces like for like. If there's injury to the epithelial lining, it replaces itself by the same epithelial lining. However, the muscle and serosal layer heals by fibrosis. That has come out before. For tissue for fetus, rather, fetus heals via scarless by forming without fetus heals without forming scars, and that's because they exhibit high level of type 3 collagen, hyaluronic acid, and they do not really have inflammation. So particularly what you see is they exhibit high level of type 3 collagen. This has come out before. And it's not postgraduate exam, it has come out in undergraduate exam, it has come out in primaries, and I've seen many other questions. So if you just elaborate high level of type 3 collagen and hyaluronic acid, hence, particularly this type 3 collagen spot has come out multiple times. Hence, they heal without forming scars. Again, this mucosa of the intestine heals by regeneration, while the muscular and serosal are healed by fibrosis. So factors affecting wound healing, we have local and systemic factors. So local factor, oxygen, infection, radiation, foreign body, edema, surgical technique. Systemic factors include age per se do not really affect wound healing per se, but then age itself predisposes the individual to many systemic diseases such as diabetes, uncontrolled hypertension, and immunosuppression, and this can affect wound healing. Hypertension per se do not affect healing. However, hypertension itself can actually predispose to harden of blood vessels, and that can inhibit blood supply to the tissue, and that can actually affect wound healing. Smoking, how does smoking affect wound healing? It then causes vasoconstriction, and then the blood vessels, the damaged tissue may not have enough oxygen for wound healing. So some of the complication of wound healing: infection, hypertrophic scar, keloid, atrophic scar. I'll just skip this. This may not be necessary. This may also not be necessary for you. This may not also be necessary for you. This may not also not be. So thank you very much. Is there any question you want to ask me? If you don't understand it, tell me that I can go over again. If you don't understand any particular place, to tell me I can go over again. Is there any question you want to ask?
No, sir.
Are you okay? Are you okay?
Yes, sir. Yes, sir. Okay.
Okay.